Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing their surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today in this episode, I am going to discuss one more image based question from lower GI tract pathologies. So our patient is a 65-year-old man who has come to the hospital with unexplained anemia, and he has got unintentional weight loss of more than 20 kgs in 2 months period. The diagnostic workup of colonoscopy and barium enema are shown here. This is figure A is colonoscopy and figure B is the barium enema. So these are the two pictures and these are the 5 questions. Question number 1, what are the investigations and findings in figure A and figure B? Question number 2, what is your diagnosis and why you are saying so? Question number 3, what are the different modes of presentation of this pathology? Question number 4, what are the staging systems and tumor marker for this pathology? Question number 5, how will you manage this patient? So now I request my viewers to pause the video and try to answer all these 5 questions. After answering, you can verify your answer with the correct answers which I am going to discuss in the subsequent slides. So question number 1, what are the investigations and findings in figure A and in figure B? So these are the 2 pictures. The correct answer is figure A is, this is colonoscopy. You are seeing a growth in the colon. Most probably this is in the cecum because it looks like very roomy. It looks like the cecum. Yeah, you are seeing these folds and all. So this is most probably a cecal growth. That is what you are seeing in figure A. Whereas in figure B, this is barium enema, where you are seeing a filling defect in the cecum. This is cecum and you are seeing this is the filling defect. You are seeing in cecum. Okay, these are the 2 investigations, namely the colonoscopy and barium enema, and these are the findings. Question number 2, what is your diagnosis and why you are saying so? The correct answer is most probably the diagnosis is carcinoma of the cecum, but this should be confirmed by a biopsy by colonoscopy or colonoscopic biopsy. What are the reasons for this provisional diagnosis? Our patient is an elderly person. He presented with unexplained anemia. He is also having unintentional weight loss of more than 20 kilograms in 2 months period, and the workup of both colonoscopy and barium enema are showing definite growth in the cecum, most probably in the cecum. So however, the diagnosis is only provisional. It should be confirmed by taking a biopsy with colonoscopy. Question number 3, what are the different modes of presentation of this pathology? So the correct answer is, okay, this is a colonic cancer, but this colorectal cancer can affect right side of the colon, left side of the colon and the rectum. So the rectal carcinoma is totally different from the colonic carcinoma. So depending upon the site, there are some characteristic modes of presentation of this particular pathology. The right-sided colonic tumor is only 10%, whereas this malignancy is affecting the left colon 30%. But the commonest area of affection is the rectosigmoid or the rectum, 60%. Suppose if it affects the right colon, which is in our patient, most probably it is right colonic carcinoma or the cecal carcinoma. So what the patient will present, I told you, unexplained anemia due to protracted occult blood loss. Because of this tumor, there will be microscopic or very minute blood loss from this tumor, and that is the cause for the anemia. Patient also can present as a mass or lump in the right iliac fossa. That is another mode of presentation. Or patient also can present as pyrexia of unknown origin or PUO. Patient also present as a case of appendicitis when the carcinoma of the cecum occludes the appendicular orifice. So whenever you are encountering a patient with appendicitis, especially if they are elderly patient, you have to rule out carcinoma of the cecum. For example, if patient is above 50, 60 or even 70, you must exclude carcinoma of the cecum. Of course, all these sites, whenever it is carcinoma, patient also will give history of weight loss. Suppose if it is left-sided colon, patient will have pain in the left iliac fossa, and that will be referred to the suprapubic area. Apart from that, the patient also will have alteration of the bowel habit, that is both constipation and diarrhea. This is the most common symptom, because this is common in the left-sided colon, because here the stool is becomes solidified, whereas in the right-sided colon, this alteration of the bowel habit is not a normal, mode of presentation, because the fecal matter here in the right-sided colon is liquid in nature, and the bowel also has got a very roomy, very wide bowel, the right-sided colon, compared to the left-sided colon. Whereas in the left-side colon, the fecal matter will be solid in nature, and the diameter of the bowel also, compared to the right side, it is narrowed. That is why the patients are going for this alteration of the bowel habits. Initially, patient will be having constipation because of the compromise of the bowel diameter. After some time, whichever fecal matter is stagnant, proximal to the growth or proximal to the stricture, it will get liquefied by the bacteria in the large bowel, and then it will become liquid in nature, so that alternatively the same patient will have constipation for some time, and then if the fecal matter get liquefied, the same patient will have loose stools also. This is a very characteristic feature of left-sided colonic carcinoma. You can also feel a lump in the left iliac fossa, and patient also can pass small caliber stool or pencil thin stool, because of the narrow lumen. These patients will pass low caliber or small caliber stool or the pencil thin stool. Of course, these patients also will have loss of weight. Coming to the rectal carcinoma, which consists of 60%, patient will have blood and mucus per rectum. Patient will be passing blood and mucus per rectum. This is the most common and earliest symptom. Patient also they have sacral or perineal pain because of the local infiltration. But the characteristic feature or the hallmark symptom for rectal carcinoma is tenesmus. That is inadequate sensation of evacuation of the bowel. That is what tenesmus. This happens only in rectal carcinoma. And of course, here also patient will have weight loss. Question number 4. What are the staging system and tumor marker for this pathology? So tumor marker is carcinoembryonic antigen, but this is not specific to colorectal carcinoma alone. But this hasn't got any diagnostic significance. But during the follow-up to pick up early recurrence, Okay, it is very useful, this tumor marker. So the classification is Duke's classification, and now currently we are following the modified Osler-Collar classification. The Duke's classification, it is ABCD. So Duke's A, invasion into but not through the bowel wall. Duke's B, invasion through the bowel wall but not involving the lymph nodes. Duke's C, involvement of the lymph nodes. Duke's D, widespread metastasis. So the modified Osler-Collar, it has got stage A, stage B is B1 and B2, stage C also C1 and C2, and then the stage D. So stage A, it is limited, the tumor is limited to the mucosa. Stage B1, it is extending into the muscularis propria but not penetrating through it. Nodes are not involved. You can see it. This is grade A. This is grade B1. It is penetrating but no node involvement. Whereas B2, okay, it is B2 is penetrating through the muscularis propria. See, it is not only penetrating, yeah, it has come out of the muscularis propria, and okay, the nodes are here also, nodes are not involved. In stage C1, it is extending into the muscularis propria but not penetrating through it, but nodes are involved. Here you can see this and this are same, but here nodes are also involved. That is C1. This and this are same, but here node is also involved. That is the difference. So then the stage D is distant metastasis. So this is you must know the modified Osler-Collar classification, you must know. Apart from that, TNM classification is also there. Question number 5, how will you manage this patient? So the correct answer is immediately after colonoscopic biopsy confirmation of the diagnosis, we must do staging of the disease by appropriate investigations. In late cases, we have to do only palliative treatment. Only in early cases, you have to do surgical intervention. If it is cecal or ascending colon carcinoma, we must do radical right hemicolectomy. If it is involvement of the hepatic flexure of the colon, then we must do extended radical right hemicolectomy. So this is the treatment. So thank you very much for watching this video. If you think that these videos are very useful, kindly subscribe to this channel and share these videos into your social media. Kindly click the bell button also to get the notification regarding my recent uploads. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye bye.